I am the director of the Center for Healthcare Marketplace Innovation, the founding director, and it's a new center, and it really is building kind of a new model. And many of you probably heard Chancellor Lyons talk about the fact that Berkeley is really interested in going really from ideas to impact all the way through, and that's continuing to build and scale that model. We're doing that in our own little domain of AI and healthcare, but really trying to assemble the building blocks that go from basic research on AI and human behavior all the way through to actually launching out solutions. And actually that's going to be sort of thematically what I'm going to try to do today. So talk about pieces of the AI and healthcare ecosystem and going from the core research all the way out to some solutions that we're trying to launch. I did see some slides up there. There we go. Okay. All right. So just to set the stage, this is like required for anyone talking about healthcare to tell you it's really, really important just on an expenditures basis. But I want to do something a little bit more focused. So first off, we're spending, and it's going up now, but we're spending close to 20% of GDP on healthcare in the US. And you'll notice that, in fact, it's both higher in levels, but also growing substantially faster than a comparable country average. What is a comparable? It's basically a basket of OECD countries that have similar other features. So we're doing something very, very different. And if we go over here, and again, I'm happy to supply a lot more numbers, but just to put this in perspective, where do the gaps really come from? They're coming from these big buckets, which is inpatient and outpatient care. So the actual care received, we're spending a lot more on that. And also, if you look at this green bucket, that's administrative cost. These are two big areas where the US really stands out as different from other comparable countries that are achieving, frankly, better health outcomes. And this suggests to me an opportunity to think about how there's lots and lots of things that have to go into this to change to shrink those gaps. But it's a particular area where we might think some of these novel tools of AI might really help us. And to put in perspective this opportunity, there's some estimates. This is just direct administrative costs, like things that we know is administrative. Of course, there's a whole bunch of things going on in here that also are administrative cost. And there's some estimates that up to a third to a quarter of healthcare spending actually could be administrative spending. So if we think about that, that's real money, right? Even if we took half of that away, that's sort of 3 percentage points of GDP. We could essentially eliminate poverty just by cutting down our administrative cost. I mean, obviously, there's a lot of reallocation and things to do there. But to put in perspective, this is a big opportunity for society. Not to mention, it's a big opportunity for us. We would be healthier, happier, better access to the healthcare system. So with that grand agenda, let me tell you what I'm going to actually try to do today, which is going to be a much smaller goal, but really to think about a kind of core set of ideas that you might have as you think about the role AI can play in the healthcare system, or at least in a particular domain of healthcare, the healthcare system that I focus on. So first, I'm going to actually look at health insurance choice. So it's sort of the most mundane, but I'll try to convince you it's a really important component of the healthcare system. All of you, or I hope all of you, probably have health insurance. You may have had to select it in very different ways from your employer, for some of the older folks, Medicare, or from an exchange. We'll talk about that process, and actually that's a really interesting lens both into human decision-making as well as where we think in a simpler world, AI might be helpful. Then I want to think about actually coming into the practice of medicine. And this is talking about a core research agenda of mine, which is trying to understand from the really granular clickstream data that we've all been gathering now for about the past 10 years as electronic medical records have really expanded to the near universe of care. And again, I hope many of you haven't been to the doctor recently, but if you have, you've probably noticed that they spend a lot more time asking you questions and focusing on the computer. We can talk about whether or not that's how that affects care directly, but that means we have basically a digital trail of all of these actions at a really granular level, which is going to give us new insight into how the practice of medicine is actually occurring and what we can learn from human behavior. And then lastly, I'm going to think about taking those basically digital footprints and trying to build a completely new foundation model of healthcare. And so that's where I'll end with thinking about this new research project. And I'll maybe convince you that, in fact, language is not the semantic structure that healthcare knowledge really exists in, and that we might need a different foundation model. Okay. And then I'll have some Q&A. So AI in healthcare, this is way too broad for one talk, and that's like an understatement. Obviously, AI can be applied to vast areas of society, vast areas of healthcare, and even healthcare is still too broad, right? It's better science, right? We're discovering new proteins, we're doing new novel drugs this way. It's better medicine, right? There's predictive analytics and decision support. There's targeting, the ability to get the right medicine to the right person at the right time, even down to the granular level of the specific tumor typing. And then there's lastly productivity, right? So think about just clinically intelligent chat, right? That would be fantastic, right? Many of you probably had to wait a very long time to get a physician's appointment. Imagine that. So we think that this is a big opportunity, but what I want to convince you of is that actually under the core of all of this, what is AI? It's basically the ability to predict things really well. Okay? And there are some other applications, but what I want to think about is this idea that we can use data to predict something is going to be at the core of all of these ideas that I'm going to show you today, and it's really at the core of pretty much all of these AI applications. That it's the ability to have really large-scale novel data and predict outcomes. Okay? And that opens up a lot of applications. So really what we're going to do today is I'm going to walk you through some different applications and research projects to think about the human behavior, what we can measure. Can we extract out of that a prediction problem? And then from there, can we use a machine to maybe do a better prediction? Okay. All right. So to start with that, I want to think about health insurance choice kind of as a nice laboratory for this. And this will kind of get us warmed up on this idea of prediction and human behavior. And it turns out to be very, very important in and of itself. So this project is sort of the culmination that I'm going to present here is a culmination of kind of a series of papers studying how people make these choices and the mistakes, frankly, that they make. So it turns out that insurance choice is intrinsically interesting and intrinsically matters because it's, of course, critical for people's financial and physical health, but it also turns out to be a great lens more generally as a behavioral economist to think about making these kinds of choices, which are inherently uncertain and forward-looking and require kind of a complex projection of what might happen to me, and if that does happen to me, how will this complicated benefit apply to me, right? It's the kind of thing that human brains are not particularly good at, but if you think about the way we structure health insurance access in the US, implicitly we're asking people to essentially vote with their feet or with their bodies to get the market to function, right? We have a market-based delivery of health insurance. Markets work well when people pick products that serve them well. They maybe don't work as well if, in fact, it's a very complex choice with a lot of shrouded components of that insurance. And so what do we have today? Well, we actually don't do this, broadly speaking, by ourselves. There's a big reliance on insurance agents. Okay? So there's somebody that's ostensibly supposed to be helping you with this process. And so what we're going to first look at in this paper is both how well do humans make these choices, and then we're really going to focus on how well do these skilled agents make these choices. Because that gets back to this idea that, well, if you think about an AI to help with this, really we have to ask, can it exceed performance of someone who's highly trained and spends a long time doing this? Okay? And so what we're going to do is basically think about really how does automated recommendations, so we're going to build an AI system and deploy it and ask how these automated recommendations actually complement or substitute for that skill that exists there today. So we're both going to ask, what does an AI look like to improve these choices? And then how does it interact if we offer it up to relatively skilled agents who are doing this professionally? Okay? And I'm going to study this in a setting. We're going to focus on Medicare insurance. I'm happy to give a little Medicare primer. It's late enough in the day that everyone's awake, but we won't get. It's basically we're going to focus on a very large exchange run by Aon Hewitt. Many of you know Aon, used to be on the Man United jerseys, et cetera. Big benefits manager. And what we're going to look at is essentially their entire exchange, which was large companies use them for their retiree enrollment. And we're going to ask, how does the quality of decision-making change when we introduce these AI tools to the marketplace? Okay? But just to give you an idea about the scale of these errors, I want to go back to, this is an older paper of mine along with my frequent co-author, Ben Handel. Here we studied actually a much simpler choice. There was just a complete coverage plan and a high deductible plan, and that was it. And essentially, if you do the math, this is kind of a way to visualize it. Essentially, if we think about how much I spend and the relative value of the high deductible health plan, essentially, if I don't spend anything, it's a really good deal, right? Because I'm basically getting a much lower premium, and I save money, and essentially that keeps going. As you get higher spending, right, it's a worse deal because you have more out of pocket. And essentially, if you look in a forward-looking basis or backward-looking, either way, about 60% would be better off in the high deductible plan. And if we then add in the tax benefits, in fact, it goes up. It's right. Even you can say that actually up to 70% of people would be better off if they really understood the tax benefit. And we went to work with this very large firm that was offering up this benefit, and HR was totally confused. 7% of people were actually taking this benefit, and they thought, like, we've just given these people a fantastic deal, like a fair amount of money. Why aren't they taking it up? And it turns out that actually that information and the inability to gather that information is incredibly important here. And this paper does a lot more, but here's a good example about these perceptions. So essentially what we did is we fielded a survey that really was, essentially it was sort of a quiz on what you understand, and then linked it to the actual choices people made. And if you squint, and again in the back, sorry, I'll just tell you what's here since it's a long way back. Essentially we asked whether the network was different, right? So think about your insurance plan. One of the big values is which physicians, doctors, and hospitals you can access. In this case, it was exactly the same insurance company. They were identical. And this had been made very clear through lots of big sessions that HR put on, et cetera. But if you look at people's answers, it turns out that the share, basically when people report the wrong answer, they're much more likely to have stayed in the traditional PPO plan. So people are acting on this misperception, and this turns out to be true across a whole bunch of other dimensions of the plans. And essentially, these are real dollars. So if we estimate, a big economic model, I won't bore you with that, but we can implicitly understand kind of how much were people actively giving up, given that they perceived that the network was bigger. The average person in this company was giving up $2,300 a year because they thought they were accessing more doctors, right? So these kinds of mistakes are real in the sense of the dollar value, and I'll try to convince you shortly that they're also real in the sense of health. Another great study that I think is even simpler that demonstrates this is by John Gruber and Jason Abelak. There they look at Medicare Part D. Do people know what Medicare Part D is? That's the drug benefit, okay? And it turns out this is a nice place to study it because essentially you can ask, if I lower the premium by $1 and I raise the cost sharing on the drug that you know you're going to take, right? You should treat those the same, right? It's a premium dollar for sure and a cost sharing dollar for sure, or they're just $1. But it turns out people weight it wildly different. So they act as though a change in how generous the benefit is only 20 cents. Like basically it's only 20% of the actual effect of a change in the premium. That leads to big mistakes, and it turns out these big mistakes are actually killing people. That when people move to benefits that don't cover their medications, another colleague here at Berkeley, Ziad Obermeyer, has shown that in fact you see increases, for example, in heart attacks when people are moved to plans that don't cover their meds. So these are both real in terms of people's wallets, and they're real in terms of people's lives. And that's a big gap. And in fact, what you've also seen related to this is, and again, many of you hopefully haven't had to interact with Medicare too much, but either you may be headed, well, we're all headed there, I hope, but or you have parents that are doing this, or you're there. It's complicated. In fact, what you've seen is a really growth of plans with zero premium. And this is directly related to it, right? What would you do? What's the profit maximizing approach here? If people don't respond to premium, you send the premium to zero, and then you just have higher cost sharing because you're going to get more people and retain them. So essentially, it's not just that people are making mistakes, that in fact the market has responded by giving plans that are actually worse for consumers. So this is sort of the backdrop of this idea of, well, how could we correct this? And maybe AI could help us. And in fact, I'm going to argue that AI can help with this because at the core of this question is a prediction problem. The core question is, what might happen to me next year? And if that happens to me, which benefit is best for me? That's actually a really hard problem to do. In fact, it's arguably impossible even for an expert, which we'll come back to. But really, if you said, like, I've got 40 different plan choices, what should I choose? I'd like to say if 1,000 people just like me today went into each of these plans, what would their experience look like? And kind of what would be the best for them? And it's a little more complicated than that. It's not just how much do you spend, right? It's also risk protection, right? You're risk averse. Insurance is not just about a coupon book for what you know you have today. It's about risk protection. But that, again, is a prediction problem, right? You might say, well, if I'm risk averse, I really don't want the very bad outcome, and I might pay a little more in premium to avoid that. But it turns out if you can predict what's going to happen, you're able to do this on a personalized basis on a specific plan match, and that's essentially what we did. We built a tool to essentially do that prediction problem for enrollees, and we're going to ask how that affects their outcomes. Okay. And one thing to note about that, actually, just as an aside, this is a very, very different approach than you'd get from, say, a technologist who just came in and said, I want to do an AI for insurance. They might do what's called a recommender system, right? We all interact with them all the time, kind of most notably as Netflix. But if I create a Netflix-style recommender system, right? Netflix's assumption is if I watch a movie and I say I liked it, I liked it. So revealed preference is effective at getting you to the right product. Here, we're basically saying people are making a lot of mistakes. If we built a recommender system, we'd essentially just exacerbate the problem. Right? We'd say, oh, you chose the zero premium plan. Well, you may also enjoy the zero premium plan. And so we have to come at this from a very different approach, which is building from the ground up an understanding of human preferences and behavior. And so that's the sort of a distinction that I'll come back to. This is what happens when you have an economist who also does technology and AI work. And so it's a different perspective. There are a handful of us that are pretty involved in this, and it's kind of just a different perspective on building these kinds of systems. And we're going to come back to that also in the physician example here. Yeah?
May I ask you a question? Why do you use that term mistake? It's like these inefficiencies or scams or
Well, I could use...
Because they're built into the system on purpose. They're not by mistake.
Well, they're not built into the system on purpose. So the question for posterity is why do I call this a mistake? And it's a great question also because if I go down to the Hoover Institution or the University of Chicago, they'd say, well, nobody does make, if people chose this, they must be better off in it. So I'm taking a kind of Berkeley view that people can make mistakes and we might take care of them. But more concretely, I think that we're going to call this a mistake. So a good example, and this is sort of in the weeds of a lot of what we do, this is for sure a mistake. If I know that I'm going to take a medication with probability 1, and I treat $1 spent on that differently than I treat $1 premium, that's just losing money. Okay? So we know that's a mistake. There's other settings here where we might say, well, we could kind of rationalize it. It doesn't seem like it's a good idea, but maybe you have particular preferences. Here we know it's a mistake. And I think your more general question is, this is the way the system's set up. And I would argue that, in fact, the system implicitly, when it's designed, and this is true of lots and lots of things we do in public policy in the US, we rely on markets to deliver a lot of stuff. We rely on markets with government backing in a lot of settings, and that can get us a lot of efficiencies. And that's really was the goal here, was to say, basically, we want competing private plans to offer better, lower cost, and cheaper options to people. And there is some evidence that that can be effective, but this is where the actual demand side really comes in. If consumers can't make choices that give the signals to the companies that are going to build better products for them, then we think not only is it a mistake for the consumer, but the whole market mechanism is going to be broken. And so I think this is not just about helping consumers avoid mistakes. It's also about creating a more functioning and efficient form of competition, since we've relied on that. Yeah.
Nudge theory would argue that you should focus on default. So do you think that if AI is able to get somewhat accurate predictions on optimal plan for individuals to be automatically defaulted, that change?
So great question. And I've written on this and certainly presented ideas on this. What we're doing here arguably could be the backbone of a smart default system. One issue with doing defaults, which bring it back to AI, it's very difficult to do a default if you don't have this prediction model. It's really hard to know what's the best for you. So this is actually, we're going to study this just giving it the option to kind of skilled agents to use it, but it's a good example of you could use for smart defaults. All right, so let me just tell you what we're going to do. Essentially, it's a lot of work, but I can do it in 3 bullets. Essentially, we built a prediction model for out-of-pocket spending. So we got millions of individual people's claims data and said, everything I know about you up to year T, what would happen to you in year T plus 1? And then we're going to run them through every plan. So we know all of the potential outcomes, both the average and the full distribution. And then we're going to integrate measures of risk aversion, measures of network breadth, how much people care about it. So essentially trying to build up that individual plan match for that particular person. And then we're going to basically have these individual recommendations. In practice, all of this engine lives behind the scenes, and it comes as basically an API that can be integrated into the enrollee experience. I'll speed up a little bit just to make sure we have some time for the other things here. But we're going to study this, as I mentioned, in the Aon Navigators Exchange. To kind of put this in perspective, and I mentioned it, it's essentially retirees of large firms. They also have a under 65 exchange that's worked here. But we're going to focus on Medicare. So, for example, all AT&T retirees use this exchange. When we're going to focus on the Medicare Advantage market. So, again, keeping my Medicare jargon to at least a minimum. Medicare Advantage, for those of you not familiar, is if you opt out of traditional Medicare. So traditional Medicare is just a defined benefit that you get. If you opt out, managed care plans can offer you additional benefits, and you opt out of the entire system. That's Medicare Advantage. So Medicare Advantage is basically a full suite insurance product. The biggest players, for example, are United and Humana, so big names that people know. So we're going to study that market. Okay. And sorry, this is my best screenshot because I don't talk to them anymore, and it's a little fuzzy. But just to give you a perspective, basically you're going through, entering in your information. They're asking you a bunch of questions about what medications you take, et cetera. And then you're going to be given these tiles that are basically a plan recommendation. Oops, let me go back. This is AI at work, right? So this little thing is basically saying, here's your score and green, yellow, and red. That's what this engine behind the scenes is able to say. Actually, for you, this plan is a green plan. And by the way, this other Aetna plan here, and this is a bit older, is yellow. So that's the idea, that we can match individuals to plans. And the question's going to be, when we offer this, how does it change the recommendations when you have a lot of skilled agents doing hundreds of enrollments? Can it actually improve upon those individuals? Okay? And to give you an idea of who this is, basically, these are the agents, and we're going to separate them into groups by the quality of recommendations they give. So this is the quality of the match. So this is the highest skill. These are the ones, this is the 20% of agents who, before they had access to the tool, were really good at getting you into the right plan, and these are the worst. And if you look, basically, they're identical across pretty much all of these characteristics, which is what we want. It turns out that we have, anybody who's, causal inference, we need randomization. So it turns out when you call in, who you get on the phone is random. That's going to help us here. So we're basically going to look at the outcomes for those individuals. I'm going to actually just run over a little bit of the technical details to make sure we can get through the other pieces to it. But this just gives you a perspective essentially on the magnitude of choice error. So this is basically looking in 2015. If I were to say, how much money were you leaving on the table in expectation? There's a bunch, about 13% of people or 12% of people, they had the best plan for them. But everyone else was leaving money and expectation on the table, and these are real dollars, right? These are fixed income retirees. We're talking about a mean error of about $1,400. So there's appreciable error, and it would add that the agent variation is substantial. So, who you get on the phone randomly, so moving from the 25th to the 75th percentile, cost you $875. So there's real variation before the AI is available, even though these people are doing a whole lot of enrollments. In fact, if we look, so this gives you the idea. This is the choice error average. So the best group was only costing you $900. The worst group was costing you almost $1,800. But if you then look at experience, who they're treating, and how long they spend on the phone, there's no variation. So it's not like from a managerial perspective, you can go in and see this pattern that, Agent Kolstad's down here, and he's spending hours doing this, and that's why he's so terrible at it. It's not obvious ex ante, and maybe that's not surprising, right? It's a really hard, arguably impossible prediction problem to go and say, oh, I think your likelihood of getting cancer next year is this, and if you get cancer, then this network's really valuable, and you want to make sure you have this coverage for this biologic. That's not something that human brains, no matter how many enrollments you do, are very good at. And this then gives you the idea of basically, this is sort of one of the punchlines. So this is the choice error, and this is the choice error with the actual choice error in the 2015 versus 2017 after they introduced the AI tool. But we can actually really summarize it over here, and this is what I skipped over. We're going to build a model because what you're worried about is, well, things got better, but maybe they just didn't offer as many bad plans, right? So we want to control for this choice set danger. There's a bunch of mechanics to that. But once we do all of that adjustment, basically, we end up arguing that the baseline causal effect of introducing this tool is to save each individual $300. So essentially, we're shifting even once you've had access to an agent, adding in AI is appreciably improving their outcomes relative to sort of the whole possible error of about 800. We're getting 300 out of it roughly from the AI's first introduction. I'm going to not focus on this for a moment. This is an easier way to think about it. But we can look at basically where this is coming from. And I think this is an interesting graph that shows kind of how AI actually interacts with the humans. So this is looking at the agent quality of recommendation. And this is the ratio of premium to expected out-of-pocket. And remember, this should be 1, right? You should treat these exactly the same. And what we see is nobody is getting there. But the agents who are particularly bad at recommendations are using this heuristic of basically focusing on premium a whole lot and making substantial mistakes. After those same agents are introduced to the AI tool, that all basically goes to 1 and it's flat. So essentially what AI is able to do is take the worst performing humans and get them to quality that exceeded the best performing humans before it was available, and add to that, and we're not going into too much depth, you may have noticed that the call times are pretty long. So the primary cost to the entire business is basically call handle time. And it turns out when you use this, you also lower the call handle time by about 30%. So productivity is going up appreciably by essentially taking these lower skilled agents, improving quality, and lowering cost. And that ignores, of course, the fact that, well, if we can really take lower skilled agents and do this, perhaps we need less training, or basically turnover is less costly. This is a bunch of knock-on effects that you might think. But this sort of gets to this idea that we want to think about where human errors are coming from and why and how AI might correct them when we think about these kinds of tools and measuring their performance. And this is a very specific setting, and it's relatively simplified compared to what we're going to do later when we think about language models and stuff like that. But it's exactly the same underlying core, which is, what if we could do a much better prediction than humans are good at? How would that change the way the market functions? Okay. I'm going to jump over. We've talked about that. And I'll leave you with this, that I talked about the Center for Healthcare Marketplace Innovation, but one thing that I've really focused on and that we really, my team likes to do is not just stop with the paper. Actually, there's 6 papers here. But really, the idea at the end of the day was, would the 7th paper particularly when there's not a lot of policy change going on, be more valuable, or should we actually go out and deploy this into the market? And we have done that essentially. The exact same underlying AI is available directly in terms of getting people matched to the right plan. This has been a fascinating journey, both to see the real intransigencies of the healthcare system, as well as the degree of adoption and, frankly, the enthusiasm from enrollees to actually having an individual recommendation on their behalf. Okay, so now for something completely different. Oh yeah, in the back.
Getting better with the AI, right? My question is like, as a customer who's like getting access to this tool, when those predictions are presented and then, okay, these are the 3 best plan choices we recommend. Now let's say the predictor is saying that, okay, the chance of you getting a cancer in the next 24 months is like 80%. Now what does that do to the anxiety of the person? Like,
yeah, let's be very crisp. The underlying features here are much more aggregate than that. And I use that example because I think it's tangible about sort of a risk we might worry about but don't have a good number on. Realistically, it's much more concrete. It's much simpler, like adding in medications. This is all aggregated up to spending. So this is not being used in this case to predict directly outcomes. I mean, it is under the hood, and that information is not being presented back kind of indirectly in that manner. So it's aggregated up in terms of expenditures. So it's a great question, and the same model is doing that. So you could use it for other settings, but here we're not focused on that. I would add that one of the most interesting journeys of taking this out of the lab and into the field, as it were, is the UX side. So I can sit here and be like, okay, well, this is the right information. Of course, people want it. It's totally rational. Having an amazing product person go through, frankly, years of trying to understand how people think about predictions and cost has been incredibly important. And what I will say is that, in fact, all of that has gone in the direction of not giving as much information as we thought they wanted. So essentially what people really want, and we'll come back to this in the doctors, is, and you probably know this, when you go to a doctor, you say, what would you do if this was you or if this was your kid? That's what you want. And that's actually what they want from a broker, right? What should I enroll in? So it turns out if you essentially, what we do now here is essentially say, this is the best plan for you. Well, there's 2. And then you have to click in to get more. And that's exactly for this reason that people don't really want to engage with how much am I actually going to spend. Now, it turns out their re-enrollment is much, much higher because it's actually the right prediction for them, but they don't want to engage with the underlying data very much. Oh, wow, we got a lot of questions. Let me, why don't I take one more, and then I want to get through this other stuff. I think it'll be interesting. It's more interesting than insurance. But I'll take one question, and then we'll come back to some Q&A at the end. Yeah.
Thanks. I'll keep it brief. I'm curious about this idea of optimizing the choice. It seems to be, unsurprisingly, from the perspective of the enrollee, that you will end up in a better situation, you'll save more money. But from the perspective of the insurer, isn't it in their interest?
Isn't it driving adverse selection?
Right.
Yeah.
So what does the prediction ultimately say will happen to the plans themselves as you implement AI?
So a great question. I would say, and again, this is why I like taking ideas to the market, because you have to deal with those realities. There is a piece in the paper that says maybe this is an issue, but when you really go in and talk to a large insurer, management by actuaries is probably not a good idea in general, but it's very much there. So my argument has always been completely naive consumers is the best thing for an insurer, but a middle ground where you take risk aversion and preferences into account is actually really where you want to be, right? You're still selling high premium, high value plans to people who don't get sick. And that's why this engine is going to be important relative to what else is out there. I won't name names, but there are some kind of enrollment engines that ask, are you planning a surgery this year? Right? That makes sense as a consumer, but you never want to offer a generous plan on that marketplace. So you have to think about the marketplace. And it's a fascinating, and I could go on it, of this idea of building tools and thinking about equilibrium. Kind of are we going to get enough products there? How do I, as the designer, feel about distorting your I'm going to make my recommendations a little worse for you because I think we're all going to get more products. That's a key design question. I think it comes back to why, as an economist, thinking about these AI questions and technologies is really important because they're not in a vacuum, they're in an equilibrium. I know there's other questions. I'll speed through some stuff and then we'll have some Q&A. Okay, so what I want to talk about now is the doctor's office. And you can hold those thoughts on insurance. I'm happy to come back to it in the Q&A session. But the next section is basically going to maybe to take it to not just a little bit more complex application of AI, but I would argue sort of the vanguard of human knowledge. Probably the space that we have built the most amazing set of knowledge and dispensed it to a tremendous number of humans that do this every single day is medicine. Right? The idea that we understand the human body and can do so much for people and do that at such scale, despite my besmirching how much we spend on it, is incredible. And what we want to think about, and what I'm interested in thinking about, is actually this nice colorful wheel in the middle of this whole process. So this is from the National Academy of Medicine, basically. We're going to be interested in this extremely human process of medical diagnosis. Right? If you think about how this actually goes, right, you go into the doctor's office, you say, I have these symptoms. Essentially, the doctor is taking all of this information in and going through this dynamic process of essentially proposing hypotheses, narrowing down those hypotheses, trying to treat. Maybe it doesn't work. We go back. That process here is an incredibly complex but real prediction problem. Essentially, it's a narrowing down. It's a real prediction problem. And so what we're going to be interested in here is how this actually works in the field. So first I'm going to show you some evidence on that these are real. Doctors are people too. I know there's some doctors in the audience. And we might think that's important if we think about kind of how diagnosis is actually going to affect outcomes. If you look over here, right, all of randomized control trials, kind of everything we think about is what treatment did you get and how well did it work? But all of this has occurred beforehand and allocates you to different treatments. And we really want to think about that, particularly as I'll come to in a second, we get into designing new AI systems to think about how those will function within the healthcare system. Okay? And this is this idea that, look, physicians are working in variable environments. They have to make decisions based on complex probabilities. They get almost no feedback. Right? Imagine you're working in the emergency room, UCSF, which we're going to study. You send someone back out, they don't come back. Was that a good outcome? Did they die? You don't have any feedback. So how are you learning and refining? That's sort of the extreme version, not to be too morbid, but it's real. So what we're going to start with is actually thinking about a simple model of diagnostic decision making, and then we're going to take it to the data. And really what we're going to be interested in is this question of, within an individual, how does their current cognitive capacity affect their decision making? Right? So there's a lot of literature, which I don't have time to go through, which says, well, Dr. A is pretty different than Dr. B, or Nurse A is different than Nurse B. But we're going to take that one step further and just ask, and I'm sure none of this happens to you, but if I'm tired, or if I have a lot of things to think about, or if I had to drop my daughter at softball and then scurry in here, my thinking and presenting and what I do will be pretty different. We don't tend to think about that, but that could be a central piece of the quality and type of care people are receiving. So we're going to think about that in a new way, at least as far as I know. And the idea is going to be this model, and this is a very simplified model of testing and diagnosis, but think about what a physician is doing when they're trying to diagnose. They're saying, well, look, you might have a uniform distribution of possible diseases, and I'm going to run a test, and that's going to allow me to narrow down if it's on this side or this side. And so I run a test, and I say, okay, this is over here, and then so on and so forth, until I get to as narrow a posterior distribution as I can, and then I'm going to act on it. Now, the key insight that this work is going to build on is this idea that testing, which we observe in the data, is in the same manifold, the same space as thinking, right? So here we're going to think about this idea that I could ask you a bunch of questions, kind of think about, well, what did I learn? What could this be? And then I could end up here, or I could just order a test. And we're going to ask for the same doctor, because ultimately we're going to see a final test, so we're going to measure kind of how precise they were. So we're going to ask for the same doctor, as they have more other random changes in their cognitive ability or cognitive capacity, how does that change their specific testing for the same patient? More concretely, we're going to use the fact that patients are randomly allocated to doctors in the emergency room and say, if I have more other complicated patients over here to think about, does that change the way I diagnose the patient in front of me? Okay? And we're going to do this. This is a not colorful wheel version of the same thing at UCSF. Right? Patients can ambulate in or they come in the ambulance. Essentially, they're going to get registered information and intake. And then they're going to be assigned to a provider. As I mentioned, that's quasi-random. Essentially, they're just assigned to the doctor randomly. And then we're going to look at, this is the colorful wheel if I had the National Institute of Medicine design folks. But basically, you're going to be doing some testing, you're going to get results, and you're going to reject or confirm, and then you're going to make an inpatient treatment decision. So we could think about taking this to a lot of other settings, but we're going to focus on this relatively simplified setting where diagnosis is the name of the game. Right? At ED, you're supposed to triage people, figure out what they have, and act on it. Right? So diagnosis is the central role for the doctor and also the central use of resources here. And what we get, this is all of the distributions of, so essentially what we're going to do is take for each patient arriving, how costly is that for the doctor? And then basically bank that over their shift. And each one of these gray lines is one of the shifts at UCSF. And so you can see there's a lot of variation, both across doctors and then within shifts. So this is the mean. So of course, as your shift goes on, there's more patients, there's more stuff going on. But within each one of those shift hours, this is the interquartile range. So this is the 75th percentile and the 25th percentile. Even within those hours, you could have a very different level of cognitive capacity left if we think about the idea that essentially you could think about sort of as a free memory idea, that if I have a bunch of other things to think about over here, I don't have as much memory to think about this patient. And the question is, does that actually change the way I treat patients? And we show in the paper that, in fact, it's quite substantial, right? It decreases the number of diagnostic tests, increase the number of diagnostic tests used for the same patient, right? So if I have less cognitive capacity, the same patient comes in, I'm using more tests. And importantly, we have a measure basically of how precise they are. So it's not just that they're using more tests. We compute a measure of Shannon entropy, for those of you who are familiar, and basically show that, in fact, they're less precise. So if you come into the ED and the doctor has more other things to think about, they're changing the way that you're treated within that same doctor within the same day. And we can basically look at, this is actually a pretty big effect. So we have a very simple exercise where we ask, what if you took cognitive capacity into account when you just designed the scheduling system? So instead of just doing this random assignment thing, we say, okay, Dr. Kolstad already has a lot of patients that are complicated. Let's reallocate patients away. Holding fixed the number of patients and the number of people on staff, so there's no changing overall, it's just reallocation. We show that you could actually reduce the number of diagnostic tests needed by about 23%, right? So there's a lot of additional tests being used. What's not here, and I should add it, is we also show that, in fact, inpatient admissions would decline by about 20% as well, which is a big shift. And essentially, that makes sense. The good news of all of this is it's not as though we don't find strong evidence that this is leading to worse outcomes. It's just more expensive in the sense that it is that kind of good news that, well, if I don't really know, I'm going to admit you at the margin. But of course, we think you could be much more efficient if you were actually able to just redesign. Now, let's bring this back to this idea of AI. The other really interesting question here is, all right, we don't even need to design like the super doctor. What if we just had an AI system that allowed you to act like your best self? Right? This starts to bring up these ideas that thinking about the actual human cognition and the process of care matters a whole lot if you think about where these tools can be used, right? This isn't just about a language model that's trained on medical language. This is about trying to replicate some form of clinical intelligence that we might want to deploy. The other thing to note here, which is something that is very often lost in the design of AI systems, is which self are you actually training on, right? Remember, training data is always critical here. And if you think about the language models, they just gobble everything up. But that means you're better trained in certain domains, right? One reason they're much better at code, there's a variety of reasons, but one of which is there's a lot of training code out there to work on. Here, you might ask the question, do you want to train on all clinical actions or when there's less fatigued doctors? Right? A great example of this is radiology, where there's been sort of the end of radiologists as we know it has been forecast for like 20 years because we have image recognition. But all of that's just trained. Basically, the training data sets are used are essentially medical students working at night to label images. You might think that's pretty different. And in fact, it's even worse than that. Let's suppose you get tired. The same doctor might look at different pixels at different times of the day. And if you all lump that in together, the interesting thing is it's not just that you'll get a kind of average worse outcome. With deep learning models, actually, it could be worse than training on either set, right? Just training on fatigue doctors might actually be better. Essentially, imagine a world in which when you're awake, you only look at the middle, and when you're tired, you only look at the edges. It's going to put the wrong weights on both if you have all, I mean, that's a very simplified version. But this underscores thinking about the data generating process, thinking about the actual human action when you design these systems is absolutely essential both to the deployment and to even the base design and the data come in. Yes?
Ask, how did you come to the conclusion that this curve, the left-hand side, is better than the right-hand side? Because in many other contexts, it looks like I'm getting warmed up, I'm getting grooved, and then I get higher, right? As opposed to from the minute one, you're at your best self.
Yeah, so just to be crisp, great question. So I'm showing you this curve to show the variation. The way the model is actually run, we're putting in controls for shift hour and time to end of shift and time of day. So we're just isolating variation within the same doctor, within the same hour. Did they have more or less cognitive load? So at 2 a.m. in the SF General ED is a crazy place. But some 2 a.m.s, the same doctor, Dr. Kolstad, had more or less to do. We're asking, how did Dr. Kolstad change within that time period? So it's true that there's a lot of variation, but the practical variation that's identifying these effects is within that same doctor. Good question. All right, so let me move closer and closer to what people now think is AI. This is actually ChatGPT asking a very good question. Who won the big game? And so you can think about basically, it is incredible, and we've probably all done this. It's remarkable. It's remarkable to have this language-based semantic interaction with a machine. It's incredible what these machines can do, and it leads one to think about things like AGI, artificial general intelligence, et cetera. But ultimately, this is also just a prediction problem. It's just a net squared prediction problem, right? What is it doing? Essentially, it's asking, if I see Cal and beat, what's the likely next word? There we go. So that's all it's doing. And it does incredible things, but I want to sort of remember, even as we get, and it's important to think about this from a policy perspective, et cetera, and there's reason to be concerned, but ultimately, at the end of the day, it's still just a very, very good prediction model over a particular space, which is language. And so what I want to introduce now is this idea that, well, language might really not be where a lot of the knowledge in healthcare exists. And our newest work is to basically build a completely different model based on where knowledge actually exists in healthcare. And so we're basically leveraging similar technology to learn how doctors treat patients. And it's building on this idea that the diagnostic path is moving through a set of actions. So what we're doing is learning action paths in the same manner that you would be learning language, but it's going to be a completely different structure. And in fact, what I'll argue is that this is, actually I'll show you, right? It needs to learn the relationship between clinical actions. That's what an AI really needs to do if we think that we're going to actually go into the space of AI in medicine. It's not that language doesn't have a role. In fact, I'll talk about it later. We're going to use language to query this model. But ultimately, the knowledge exists in the actions. And so think about, right, what is the most informative test for this patient? That's something that we really would want to know from an AI. And a language model is not going to deliver that. But if we learn, they call it behavioral cloning, we learn what a great doctor would do for this patient, that's a really informative test. Okay? Or similarly, what procedure will have the most positive impact? That exists in the actions of real doctors. And I think there's a nice corollary if you think about self-driving cars, right? the corollary of all this idea that language models are going to be the key AI to medicine would be like training a self-driving car by reading the California Driver's Handbook. Right? Instead, we want to learn from real drivers. Here we want to learn from real doctors. And so to show you kind of how this is working and what we're doing with it, this is a real patient from the UCSF ED. And you can think about basically this is what an order path is, and this is what the system is learning. So essentially, this patient arrives with chest pain. This is a little bit collapsed because a lot's happening, but essentially, they're coming in, they have an initial ED, and then they're doing a CT of the chest. Essentially, they're looking for a heart attack, kind of a natural starting place, or pneumonia. Those are the two things. They're often confused. And then essentially, as they go along, you get to this, basically they're going along. Each of these clinical actions are recorded and give us essentially something to learn that actually captures incredibly rich knowledge. If you think about what's embedded in each of these actions, it is a team at one of the world's best hospitals thinking through what's going on and responding dynamically to those actions. It is not a team reading a textbook and saying, well, on average, if we have these symptoms, here's what you should do. And it's an interesting case, which I can show you, because essentially what happens is you're moving along, and we get to this chest, and then there's this thing that looks kind of funny if you think it's a heart attack. They move to the brain, and they move to the head to do a CT of the brain. Okay? That turns out to be a critical pivot, because what they realize is this patient is having a stroke. And they move into these stroke protocols, and essentially the clinical large behavioral model, the model we've built first at UCSF, pivots to say actually a cerebral hemorrhage is a likely outcome. That's because you're learning the path of clinical decision making in the same frame that doctors think, where you have this incredibly deep knowledge. If we do the same thing, this is a little bit unfair, but I don't think if we did it on a fully medically trained version, this is basically putting the same path. So if you feed into GPT-4 or even the reasoning models and say, first I did this, then I did this, then I did this, what should I do next? Essentially what you get out of it is a loop of heart attack. Why is that the case? Because the preponderance of the evidence is still that they have a heart attack. You need to be thinking to anthropomorphize it. You need to be thinking like a doctor to know that when this thing changes, we're really going in a new direction, and there's logic and knowledge there. So this is one kind of concrete example. What we are building now is a general version of this to basically learn essentially all aspects of care, because all of the care, it's different cadence and different paces, but ultimately there's an incredible amount of true clinical knowledge that is embedded in these very information-dense actions that is missing in language. And conversely, language, I don't know the percentage, but if you ask kind of what share of all medical knowledge that humans have is actually written down anywhere, 10%, 20%. It's not, most of it is basically in tacit learning, and it's tacit learning to deal with true patients with their clinical complexity. So when you hear things like an LLM pass the medical boards, that's not surprising, because the medical boards are a test. But we don't let medical graduates practice. They have to go do a residency and then train and learn and do all of those things. That's essentially what we're trying to work on here. Okay? And to kind of give you an idea of how this can be deployed, one of the first domains we're working with, actually a clinic at UCSF on this, this idea that information feedback. We talked about the fact that doctors do a lot of stuff in isolation. Well, one interesting question is, if I train an AI to act like a UCSF physician, I can then asynchronously go back and say, treating your patients, most doctors would not have done this, or would have done this thing very differently. Or, for example, doctors that achieve really good outcomes, they wouldn't order that test, or they'd order this extra test. That can be, at a first base, that's really a powerful feedback to doctors, and there's a lot of evidence, including some of my older work, showing that information feedback alone is one of the biggest drivers of quality improvement and change, much more than direct incentives along those lines. But of course, we can go beyond that. I just want to kind of give you an example of the potential power of having a clinically knowledgeable AI that's distinct from a language model. I see some questions. I'm going to just wrap up quickly here, and then I'll go Q&A if that's fair. So just to kind of keep on this theme of what CHMI is doing, so we are taking this idea out into action. So we have a substantial relationship with Providence Healthcare. Some of you may be familiar with it, particularly for the Pacific Northwest. And then we're actually spinning this technology out again because our view is that it's got to be done right and carefully from the beginning. But then we really want to see these kinds of solutions, going from ideas to impact. And that's really kind of where a lot of my work is, and a lot of the work that I've been doing at the Center for Healthcare Marketplace Innovation is basically this idea that we want to bring these three things together to actually have, not unlike the bench sciences, right, where we go from the lab out and commercialize and then get into people's bodies. We need more of that in AI, particularly as they get more powerful. The deeper thought that's happening at universities needs to be driving the innovation more directly. And conversely, I'll be frank, is that the scale of compute necessary, right? We all know how NVIDIA stock, despite recent unpleasantness, means that these kinds of deployments are very powerful tools, and those interactions are the way to get these things at scale and to doctors and to patients. So with that, let me pause and do Q&A for a few minutes here. With the mic?
Hi, Professor.
Hey.
So my question is, there are very well-established guidelines that key opinion leaders and leaders in the therapeutic areas sit around and have consensus, develop these, and that kind of becomes supposedly a gold standard.
Yep.
So 2 questions: how do you validate the model against something like a gold standard that physicians have agreed to and published as guideline? Mm-hmm. And maybe the challenge, I love the work, but the challenge is doing this, in real world is expensive to study these kind of and prove that prospectively that this works. Is there some way to actually leverage, in every diagnostic, you're usually trying to start with some gold standard test that's available and you measure SNS against it. Is there some novel ways to actually speed the validation and so that you're not dependent on real world experiments that could take years? By then, the models are moved on and more data has come in, et cetera.
Yeah, so let me go and start at the beginning. So that is a spot-on question. And it is true that there are guidelines. I joke, but it's not wrong to say that guidelines exist when 100% of people can agree that 100% of patients should get this, and we can measure it. And that's 1%, 2% of all care. It's not a lot of it. And secondly, guideline non-adherence is widespread, and some of that's because there's not quality medicine. Some of that's because the realities of a particular patient deviate from the kind of textbook case. So we end up with guidelines. Only about 23% of guidelines have randomized trial evidence. And then those randomized trial evidence is basically saying, on average, at UCSF or Mass General or whatever sort of teaching institution did this, it was effective. Does that mean I should or shouldn't use it in my patients who have a bunch of comorbidities and other are taking other medications, et cetera? That's tacitly learned. It can be learned more effectively or less effectively. What I didn't get into, the other novelty of the way we're building this is a joint work with Maya Peterson, who's here at the stats department, who's the world expert in causal AI. So the other thing we do is we essentially can train these models to act like particular doctors. And then you can ask which doctors actually have the best outcomes that we're interested in. That allows you to say, all right, I don't have one guideline, but there are 6 ways to, say, manage a patient who's had a hip replacement, and what you're doing is not one of them, so you're out of that range. It actually expands a set of guidelines well beyond these kind of very slow consensus-based processes and into a much broader spectrum. So I actually view it as a very strong complement to guidelines. Your second question about deployment, I think, is a critical one. It's one exciting thing about CHMI and our relationship with UCSF directly, as well as our relationship with Providence, which is massive scale. It is also the reason, frankly, that we've are spinning this model out to basically have the agility and nimbleness to be able to create products that are testing the model before we get into a world in which we have to have FDA approval. For example, now decision support, it's an open question, but you've got to crawl before you walk. Asynchronous coaching you can do that very quickly, right? And if it's not useful to the doctor, you're going to learn very quickly your model's not very useful. So that's a concrete example of why we're interested in that. The other thing, which I sort of glossed over, or very much glossed over, you can use this model and interact it with an LLM. So these language models turn out to perform very poorly at basic tasks in medical data because they don't have temporality. So if you think about all of the efforts to do, say, automated prior authorization, despite, people are getting in trouble for it, those are very simple models that are clunky. What they really want to do, or many want to do, is basically to say, let's extract, a doctor sends over 200 pages of background to figure out whether this next surgery is appropriate. It turns out you think that LLMs could be really good at saying, I need the critical data to measure this. They're terrible at it because of this temporal and clinical logic that they can't get, right? If you need to have physical therapy before this, it can't tell whether the physical therapy you had 2 years ago versus 2 months ago, which one is relevant, right? And the only way to get these to work right now is they have teams of doctors review and mark up these notes and then essentially train them to focus on these things. But you're constrained, basically. That's not a scalable model, right? If you want to do that for everything we get prior auth for or everything we... So that's an exciting thing where we basically integrate the large behavioral model with a large language model that makes a clinically functional LLM that is distinct from what's out there. So that's a long answer, but hopefully that goes in that direction. Yeah.
Out of curiosity, so the goal is to optimize. I'm talking about the use case of reducing the test, the UCSF case, to optimize for best health outcome and as much as possible lower cost or lower time. Does that not run into issues that relate to concerns about medical malpractice that would lead doctors to do things that might actually not align with what these models would recommend?
Yeah, so great question across the board. So medical malpractice, there are different estimates, sort of maybe the best estimates are that perhaps up to 3% of spending is sort of extra stuff for medical malpractice. Now that varies across places. The key to that is that medical malpractice variation you would think would show up in the cross-section, right? That states with more concerning malpractice laws would just have different practice patterns. And there is evidence for that. What we're studying is at least largely distinct, and we're saying within your head, within your individual, do you change through the day? Which I think there's less of a view that that's a medical malpractice question. But it is true that basically over-testing is a big issue, and it's related to it. And I think it's related also, frankly, to the question about what could be some challenges around scaling up these kinds of AI. It's one thing to have one doctor sued. It's another thing if you've basically scaled this to have an algorithm. And so I think that is very much terra incognita. In general, insurance for these AI models is I'm sure there's a bunch of reinsurers that are writing policies because no one else, pricing this risk is very, very difficult because it's sort of known unknowns, to use our Rumsfeldian nomenclature. Yeah. Oh, sorry. I'm being told where to.
Hi.
Just point me.
Great. Thank you for presenting this research. I find it very interesting. I've been a nurse practitioner for a good amount of time, and a question that always comes to mind, and you shared that physicians or practitioners are really just kind of looking at their computer a lot, gathering information to be able to make a good clinical diagnosis, to also get paid, right? So a lot of these EHRs are primarily to get paid, and to make sure that you have the data to prove it. And so I like what you mentioned really early on in the presentation about, it's not, I forgot what you called it, but having more interaction with the patient. And it would be great to see more research, maybe you know more about it, but research in voice recognition in the clinical space. I know it's already happening in the security space. One of my colleagues works in ClearSpeed, and there's voice recognition for security systems and things like that. But wouldn't it be cool if there was like this thing that was like capturing the visit and being able to capture the tone and maybe, risk that's happening with individuals, so that there's some processing going on with the clinician as well, because a lot of people come in with compounded diagnoses that really go away from the standards of care.
I mean, I think that's a great example. So to be crisp, but again, I'm doing this very quickly, the interesting thing about the model as we built it, the V1 that's in UCSF is just on these actions. But it's actually a multimodal model in the sense that it can say what inputs are coming in, right? So you can link in images, you can link in voice, and ask essentially what you really want is, what is all of the information that was available to the clinician when they made this decision, and then what did they decide? Then you start to learn other signals that you're interested in. So it's absolutely correct to say it. And I think you're going around it a little bit, but it's also true that we're thinking about this from a patient perspective. Practicing medicine sucks these days. That there's massive burnout. It's related to EHRs, it's related to payment. One hope I have is that by being able to scale clinical knowledge in a way that we've never been able to before, is that you're going to relax the labor constraint, but that will keep where practicing is happening, it will be the hardest and most complex and things, and basically making it more reasonable to practice medicine again, as opposed to a lot of the stuff which is handling inbox messages or talking to a worried patient, which matters for them, but that's a very different beast. And so imagine a world in which I can access 24 hours a day the vanguard of clinical knowledge because I have an AI that my doctor has allowed me to. Essentially, concierge medicine could go to everyone, and some of it's going to get triaged up. Some of it's going to say, okay, I need more information. I'm going to automate ordering these tests for you. To do that, you need clinical knowledge. Like, that's the central thing, that sort of this idea that what is the scarcest thing in the healthcare system? It's clinical knowledge. Why do we require doctors to do things like administrative work for payments? It's because the long tail of possible need for clinical knowledge, right? 99% of the time, there's nothing remotely clinical about what's being charged. But because that 1% happens, I have to have the highest paid, most skilled nurses and doctors reviewing charts, interacting with coding. One hope is that as you can scale that knowledge through AI, for example, you can actually transform some of the underlying cost structure. But it's a great question. I don't know where everything is going, but we need to have a holistic data input if these things are going to be successful. We're done. Oh.
So over here.
Oh, yeah.
I really like what you just said, because I'm thinking, and this relates to what I'm about to say, I'm thinking that we need to free up the doctors to have more doctor interaction with patients available, and free up the doctors to treat more patients accordingly. My comment may be a totally different research study or whatever, but it seems to me that medical care today in the U.S. is primarily focused on cure versus prevention. So it's doctors studying what's in the literature and what they've learned in their experience, but do we use a knife or a drug, as opposed to do we use nutrition, diet, physical change, happiness quotient, other things in the lifestyle. And I don't know if these are things you've considered or thinking about, or is there anything going on out there?
Absolutely, and I'm going to be quick because I know we're at the end of time, but I do want to just quickly address it because I think it's really, really important. One hope, and I mentioned this as sort of a way to get at different outcomes, right? One reason we focus on direct actions is, remember that there's the treatment and the outcome. Well, that's a lot easier to study if I say you got a stent and then you didn't have a heart attack, or you got surgery and you didn't get an infection. That's the quality measures we use today. I would argue that not getting an infection is necessary but not sufficient for a high-quality knee replacement, right? You want to be happy and skiing and doing whatever else it is. If we can start to link those outcomes back at better scale, and I do think these kinds of tools are going to be essential to that. We can go further on, more prevention, but I think these are critical issues. So thank you, everyone. I'm happy to chat after if other people have questions, but appreciate your time and attention.